Hi, this is Dr. Mahadevan, and we're going to do our abdominal pain discussion case with our expert analysis provided by Dr. Matthew Strelo of Stanford Emergency Medicine International.
Thanks for having me here.
Great, and let's start. Dr. Strelo, we've got a case. This is Travis. He is a 35-year-old male with abdominal pain for about 6 hours. It's getting worse, and he had one episode of vomiting, and as a result of this, he is coming to the emergency department to get seen. So let's take a look.
Yeah, I was in a lot of pain on the drive over, but I feel okay now. Figured they'd assign me another nurse.
Just doing my job.
So things are going pretty well, huh?
Your temp's 99.4. Your BP is 124/80. One of the docs will be in to check you out.
All right, so temperature of 99.4, blood pressure 124/80, and one of the doctors is going to come in to check him out. Dr. Strelo, if you were that doctor, what other questions might you have for this patient with abdominal pain for about 6 hours?
When I have a patient with abdominal pain, I still go back to the kind of OPQRSTU. So I'm going to talk about the onset. Was it gradual or rapid? How severe was it? And in abdominal pain, a really important question, I think, is to find out whether it's worse with movement or, on the car ride over, in this case, was it worse with bumps or movement and things like that? Other things, does it go anywhere? Is it coming from anything? Especially, does it radiate to the groin or testicle area is always very important.
Okay.
And then he said it got better during that time. Did it get better all of a sudden, or did it get better kind of just gradually?
Great, great. So there's abdominal pain. There can be a lot of different things going on, and the history is really critical in terms of trying to narrow your diagnosis, your differential diagnosis. So in a 35-year-old with this kind of abdominal pain, what are some things that you might be worried about in terms of the differential diagnosis?
Well, I think at the top of your differential diagnosis in someone around this age is going to have to be your surgical causes. And so appendicitis resides at the top. It's one of the most common surgical causes in this age group. I also like to think of other things that you can see in this age group, such as testicular torsion in somebody who had severe pain that is now better. And I think kidney stone. This patient was in a lot of pain, he said, and now he looks quite a bit better. He says he feels quite a bit better. So I think kidney stone's got to be in there. And then there's other things that are less common and probably less important to get the diagnosis, but just to make sure that you've established that it's not one of these other more significant causes, such as gastroenteritis. The patient's been vomiting, so has there been any diarrhea or other signs like that? And then there's obviously infectious colitis and other causes of abdominal pain as well. So, the differential in abdominal pain is pretty long, and you can try to divide it up based on where the abdominal pain is. But really what you're trying to do is find the causes that are high risk and require intervention versus those that will self-resolve or get better on their own.
Very well said. So in this particular case, this gentleman, did he have any red flags in his history that made you worry about a surgical cause, as you were mentioning?
Well, I think the duration, anytime if you get abdominal pain for an hour or something like that, that worries me. It sounded like the pain was more significant than the vomiting, and so they'll often say surgical causes, the pain will come first prior to the vomiting. And then I think the severity of the pain was also concerning. So, it was severe on the ride over. We didn't really ask whether it was worse with bumps or movement, but those peritoneal signs are going to be a red flag we're going to want to watch out for.
Absolutely. So red flags are items from the history or physical exam that raise concern for dangerous diagnoses. And in this particular case, as Dr. Strelo said, he mentioned that it hurt on the ride over. So any patient that says, it hurts when I walk or it hurts when I hit bumps in the road, certainly makes you concerned about peritoneal findings. Absolutely. Let's move on.
Steve Curtis, 35-year-old detainee with abdominal pain, ruled out IP.
Now we got a detainee.
That pain was 10 out of 10, now it's resolved.
Resolved, that's convenient. Hello, Mr. Curtis, I'm Dr. Clemente. Are you feeling any tenderness at all anywhere?
No, it's better now.
His right count's 10,000.
Well, that's not very impressive at all, now, is it?
Pulse is down after a liter.
It was pretty painful for a while.
Yeah? Could be the stomach flu, though, right? I mean, you live in close quarters. That kind of thing can run rampant to half the population.
All right, so his pulse is better, his white count's not that high, it's only 10,000, his pain is resolved, and the doctor thinks it might be stomach flu. So what do you think about that, the diagnosis of stomach flu in this patient with abdominal pain? It did get better.
Well, I think that that's actually probably one of the reasons I don't think it's stomach flu. So as a general rule, stomach flu doesn't get better immediately like that. That's a gradual onset, gradual offset most of the time. So for someone to rapidly get better like that, that seems unlikely.
Okay, and if you were worried about something like appendicitis, a surgical diagnosis, what are some things that you would look for on your physical exam? He did a very brief physical exam, but if you were to do a physical exam, what are some things you might look for?
Well, I think that, you know, anytime I'm evaluating the abdomen, I'm always looking for peritoneal signs. So one of the things that he didn't do is he pushed down on the abdomen, but did he really check for rebound tenderness? Did he do either a cough, you know, which you can do with like a cough test, or, you know, pound on the bottom of the patient's heels? Oftentimes, if they say they're feeling better, I'll have them stand up and kind of try to jump or hop and see if that hurts a lot. If they're not able to do that, then I kind of jiggle the bed or do something else to kind of move the abdomen and see if that hurts.
Absolutely. So any of those things, rebound tenderness, having the patient cough, having them drop onto their heels, bumping into the bed, if that causes pain, certainly raises concern for peritoneal findings. What about appendicitis itself? Are there any special tests that you might do to elicit, you know, signs of appendicitis?
Well, the appendix can sit in a variety of different locations, and that's one of the reasons that you can't just count on it being in the right lower quadrant. And if the appendix is sitting posteriorly, there are some signs to look for, such as a psoas sign or obturator sign. And the other thing that you can look for is something called the Rosfing sign, where you have tenderness on the when you push on the opposite. So in the left lower quadrant, you get tenderness or pain in the right when you push on the left.
Great, great. So let's just take a look at these things. So as Dr. Strelo said, it's always dangerous to try and force a diagnosis on a patient. In this particular case, stomach flu is very unlikely because it doesn't fit the clinical picture at all. And it's very important, anybody with an appendix that comes in with abdominal pain, to be concerned about appendicitis. It doesn't mean that everyone has appendicitis, but it should be at the top of your differential, as Dr. Strelo had mentioned. And then there's some really important physical exam findings. The one depicted here on your screen is guarding, which is when the doctor palpates the abdomen, or in this case, the right lower quadrant. You can see the muscles of the abdomen contracting, almost guarding and protecting the abdomen from your hand. And then there's rebound. If you push down, in this particular case, push down in the right lower quadrant, and then release. That causes an increase in pain. And this particular finding, in addition to the other ones mentioned by Dr. Strelo, concerning for peritoneal signs, which all point to possible surgical causes of, or surgical reasons for having the pain. And then finally, if your appendix is retrocecal, it may not hurt when you push on the abdomen, but the appendix can irritate the psoas muscle, so you get a positive psoas sign as depicted here, or it can also irritate the obturator muscle, and so you get something called a positive obturator sign when you internally rotate the hip against pressure, against your resistance. It causes the patient pain, and it should never hurt.
I think that guarding one is an interesting one that you brought up, because a lot of physicians, I see them put their hands on the patient and push down really quickly. And when you do that, I think you elicit guarding in a lot of people. But you really, if you lay your hands on the patient gently and wait for a second, wait for them to relax, and then push, and then they have kind of what we would call involuntary guarding. That's where I really get concerned. But I think if you come in and you're really aggressive like that doctor was, you're going to get guarding more, you know, most of the time. So you really need to do that gently. But if you do see it, it is concerning.
Absolutely, and you might misdiagnose or think about a surgical cause when actually the patient's just ticklish and you're going in there too fast.
Exactly.
Agree.